And so, as you know, this has been a segment for us, this season. And I'll sort of anchor it for us, right?
Sure.
And it's just a reminder to those that are frequent listeners and then also those that are new listeners. We talk about the Make America Healthy Again movement because it is fundamentally going to impact nutrition in a variety of ways in our nation. And right now, I like to say that we've spent the last 30 years being gaslit by Kellogg's and being told that avocados were bad because they had fat and frosted flakes were great because they had vitamin B3 in them.
Uh-huh.
And now we're being told that those same frosted flakes are literal poison and they're killing you. And both of those things
Seems
just,
dramatic.
yeah, and it gives you whiplash if you're not careful. And both of those things seem to be missing core information. And as a now 12-year dietitian, isn't that gross? I've been a dietitian 12
You're
years.
old.
I'm old. Case has turned 12 last month, actually. So, as a 12-year dietitian that's worked with literally 15,000 patients plus in my career, I have this weird thing called the synthesis, right? There was the original hypothesis that fats were bad and that sugar could do no wrong, and now we're at antithesis, which is that no, fats are everything and that sugar is the devil. Meanwhile, we've not addressed overarching calorie or anything, and I felt very compelled to apolitically, as a profession, say, hey, we know the synthesis of this conversation. So could you loop us in and we could save you like rewriting a bunch of shit like way too far to the other side and then have to rewrite it when you realize why that was wrong? Like we've got some notes and it's not because we're bought out by big ag or whatever accusations exist.
Big dairy.
Yeah, big dairy, big food, whatever you want to call it. It's because we have a fundamental understanding of how people interact with food, and we understand that the core issue is an inability and misunderstanding of moderation. So, at the beginning of this year, when MAHA came in and they were going to be bringing sledgehammers to a situation that potentially deserved scalpels, I felt like it was a great opportunity for me and for this podcast and for our team to speak up and say, hey, we have great insights. And so for those listening, that is our intention in this. It's to have a good, strong dialogue during a time when dialogue is the only way forward. And so with that, I would love to give you a chance to scream from the rooftops on this. Bring us up to date on your MAHA at a glance, and then
Sure.
I've got some little MAHA events that we can dig into together.
Yeah. I mean, my overarching scream from the rooftops in terms of MAHA, it's not a lack of scientific evidence. It's a lack of we're not doing the things. Americans aren't doing the things that we're saying should be done, right? There is a massive lack of fruits and vegetables consumption. There is far too many calories consumed on a daily basis. And this is for the vast majority of Americans, right? Not
Well, and if we're gonna
everybody.
make policies based on averages, we probably should identify
Look
the
at the
averages, which is what we talked about earlier in this episode.
So it's the lack of fruits and veg. It's the overconsumption of calories in general, far too much added sugar in the diet. We're not meeting or coming anywhere close to the recommended exercise requirements, right?
Yeah.
Which if AHA, American Heart Association, 2.5 hours per week.
Yeah.
Not many people are meeting that at all whatsoever.
Nope, it's like 8% of people or something. It's crazy.
So if we look and we say, what if we were to just like do that? What would America look like if we were actually doing the things? But I will also sit here and say, like I've said before, we are overworked, overstressed, addicted to screens, the access to movement. There's a missing puzzle piece. And I guess my thoughts are, is removing certain additives and foods the answer to those questions? Probably not. But is it going to do any harm? No.
Yeah.
But I think we're missing a key piece of the education, the incentive, the incentives of doing the things.
Yeah.
What if we were going to say, hey, this is what we need to do, and here's your incentive for getting it done?
Yeah.
I think more Americans would be doing it.
Beautifully said. How it's It's funny. We talked about this a couple episodes ago, but it's one of the funny things about Maha a couple months back is they were criticizing my pyramid. And there's two things wrong with that. Is one,
Ancient.
it's ancient, but it's also to say that no one ever even ate it. So they were like, my pyramid has made everybody fat. And it's like, no, that's not what happened at all. Nobody's been eating my pyramid because it was a 2,000 calorie diet with like, it was a bit grain heavy. Yes, it was a bit sugar. Like,
It was a little light
we
on the
could split
fats,
hairs
sure.
on the macros. Like, yeah, for sure. The protein was a bit light, but the objective truth is that like that wasn't reflective of the average American's diet.
No.
But then what's hilarious is we retired that in 2012. So like
Yeah.
13 years ago and replaced it with my plate, which was make half your plate fruits and vegetables, make a quarter of your plate protein, make a quarter of your plate grains, which just for fun would mean you have a 4-ounce protein source, a cup of some sort of carb, and then a giant salad with fruits. And if you ate that and then added a fat sparingly on those 3 meals, that would be approximately 1,800 calories. And you would be consuming 6 cups of fruits and vegetables a day. You would be consuming about 150 grams of carbs a day with like 30 plus grams of fiber. And you'd be getting over 100 grams of protein a day. That's really good advice.
That would make America healthy again.
It would, but no one's doing it.
Right.
And so the problem isn't that my plate made people fat. The problem is that my plate, no one even knows what we're talking about because no
Yeah.
one heard about it and no one did the things. And so you then get to, okay, what you're saying, what can we do from a policy perspective to change this? And if it's a hot take on my plate, I'm over it
Yeah.
because it didn't work. And so let's try something new.
Mm-hmm.
And what you said is perfect. Yes, taking certain candies and chocolates and things off of EBT and funded foods,
Mm-hmm.
stating that if we're going to pay for your food, we want to pay for healthy food.
Which would hopefully mean better access.
Well, and that's the comment I'd make is that if you're going to take those away, what are they eating instead is a very real question that as
Right.
dietitians, we're like, hey, so like, are the things that they're going to eat instead available, or are you just taking their food?
Which is problematic.
That's a problematic thing. And then from there we go, okay, where is the produce in this conversation? Because we said it earlier in the episode, the average American consumes a serving a week of both, of each fruits and veggies.
There's
So like,
room for improvement.
yeah. And that's where in this comment where we've been kind of hovering in the MAHA is we had the initial removals of stuff and it was kind of like this, okay, removing first feels a bit off because like putting things in to replace those removals probably needs to happen. But these are also the easier things to do and it makes it feel like there's momentum and it makes it feel can do. So I kind of get the pomp and circumstance, but I'm going to hold tight to wait for like what is the incentive to like replace? What's the additions when we're talking about subtractions? And I got a little hopeful a couple months back because they started showing that they were engaging with food subsidy groups to better improve access to fruits and vegetables in schools and fruits and vegetables in low income areas and commoditize them in a way that might make them actually affordable because right now fruits and veggies at a gas station don't exist because the margins are so slim.
Mm-hmm.
The gas stations can't afford it and they lose so much money on them. So the only way to do this is really to like subsidize fruit and vegetables so that they are more affordable, so that they can be more accessible. And there have been words of conversation about that, but we're sitting here a couple months later, still waiting for the back rooms to reveal. And that's where the things I had on our notes were that one, there was a report sent out here a couple weeks ago, and it was focused on basically the Make America Healthy, again, focused on the kids. And it was like, we're going to get them to basically like improve their nutrition. And that's going to be by adding good things and taking away some not so good things. And we're going to work on them moving more. And that's about as much detail as we got.
I like the ideas.
Yep.
Is it going to be feasible? Let's see.
Yeah. And that's where the devil is in the details at this point. And policy is a time consuming thing. It lags, but we need to be very intentional about our policy. And some of these initial shakings were obviously disrupting in a way that may be necessary, but also needs to have like clear plan. You can't just bring a sledgehammer to something and go, oh, we'll remodel later. It's like, no, like probably have the schematics first because that would be a good intentional project to do. And so we don't have a ton of MAHA news on that front, unfortunately, but you and I are on the same page with what we're waiting to see. And as dietitians, I think we're really waiting to see, what are you doing to change the engagement strategy so that the thing we've been saying for like 40 years, which is eat more produce, starts to click, and
Mm.
incentives are going to be mandatory. Education is going to be mandatory. There are opportunities that dietitians are robustly a part of. And what's really frustrating, they don't seem to be bringing us up very much.
Nope.
And so the news that we do have today is there's been two main calls to action that we've seen. And one of them is that they brought Ben Carson in from the Housing Authority, and he is a retired neurosurgeon, so he is a doctor, to run the nutrition aspect of the MAHA. And so he's now going to be a part of nutrition and housing. And that means he's going to be a part of like rural health and nutrition access. And his background seems,
It doesn't seem like he has a ton of work in community nutrition.
yeah, I hope that he has a great team of people that do. But once again, we have this doctor that has no real relevant experience that's running something that is not what their training was in. And we then also heard the great, brilliant idea of, wait, what if we just made sure doctors took nutrition classes in college? Because then they'd be better equipped to prescribe nutrition. And we hear once again, there's this professional, I'm going to call it delusion, that a specialist, I have immense respect for physicians. I'm going to actually hedge this. I shouldn't even have to, but I'm going to hedge this. I have immense respect for physicians, but I also recognize that they are a specialist. They went to a school for a very long time to deal with reactive acute care of a bunch of pathophysiologic conditions.
Right. Which they're very good at typically.
Yes. And they have all sorts of tools in their toolbox in medicines that they prescribe. You and I went to school for years to do the lifestyle interventions. We've studied nutrition and in nutrition and environments and cultural aspects of food and nutrition. We've dove into micro and macronutrient metabolism and all sorts of biochemistry and physiologies and organic chemistries specific to nutrition so that we can speak to this. And we're looking at a medical model right now that we've built a business on that is, hey, right now the doctor sees you for 5 minutes. They're basically going to put a Band-Aid on the most like acute thing they can. And they're going to wait until you're like too sick to function. Not because they want to, not because they're malicious, but because
That's
our
the
model won't
model.
allow it. We've built a private practice where we sit with people and spend a year or two engaging with them through repetition, troubleshooting, and we create these amazing outcomes. And you have the audacity to think that the solution to our nutrition crisis is for that already overworked, overstressed,
Overscheduled.
and over specialized person to take a quick nutrition class in college so that they can add that to their 5-minute spiel. I call bullshit. How do you feel?
Yeah, retweet. That it's rough. I think it'd be nice. I would love them to take at least Nutrition 101 so they have some sort of, which is not, I don't think people realize this, that's not a requirement of most med schools.
Correct. They do not take any nutrition. And again, I mean, I took pharmacology. Like
I did not take that. No, thank you.
Yeah, I took it as an elective. You know me though.
Well.
But it's all to say like, but it's just to say I don't mind having exposures to other things. Like I took a bunch of therapy related courses. I did do the pre-med track, so I took a bunch of med adjacent stuff. And so I see the value of being able to take our expertise and scope of practice and pair it like a Venn diagram, which means there should be some overlap.
Right. They should be knowledgeable in the fact of, hey, this is what nutrition can do to certain disease states to prevent, further chronic disease development because they have the knowledge of the pathophysiology.
And then knowledgeable enough of the providers around them to make a referral.
The other thing is people don't know dietitians exist.
Yep.
That's the issue.
They think that we're the ones in the hospital giving them Mighty Milks.
Yes.
And
or the one to complain about the food. Oh God, that was the worst when I was in my inpatient. But it's a lack of, and you've said it before, playing in the sandbox. Is what if you went to your PCP and said, "Hey doc, here's the issues I'm having." Okay, doc says, "You know what, your blood pressure is a little high. Your A1C has been climbing. We'd like to work on some body composition because of some weights continuing to kind of creep up throughout your lifetime. What if that doctor says, hey, right now, let's add this medication for your blood pressure, and I want you to go see this person and this person, right? I want you to go see a dietitian and I want you to go to see a personal trainer. And that person has access and coverage to go work with those individuals and work on the lifestyle piece, the actual root cause, and make the behavior changes. And then the PCP says, and we'll check back in a year, as they always say, or 6 months, right? 6 months in a year.
Exactly.
And during that 6 months, I want you to work on these things.
Yes.
It's the quarterback, like you've always said. If they actually act like the quarterback and say, hey, you need to go here, here, and focus on that, that patient has a lot more of a roadmap to say, okay, I'm in charge of these things. I can make a difference.
Well
As
said.
opposed to the, yep, we've got an issue here. You're in for constipation. That's why you're so bloated. Here's Miralax. Keep on doing what you're doing.
Yeah.
And which I don't want to chalk it up and say, oh, all doctors just are dismissive.
No.
Because they're not. They're treating the issue you're coming in with, which is their job.
That's their job. That's their role.
But I think the next step is adding nutrition courses into their med school going to solve this? Maybe. Who knows? But maybe if they know that we exist, they then say, hey, add Miralax in, help with the constipation, then go to a dietitian and figure out the root cause if it's dietary, lack of hydration, lack of fiber, lack of movement, whatever it might be.
Yeah. I would love for them to have enough nutrition education that they know it's time to refer to a dietitian.
Yes, which maybe that's 2 classes.
Yep. And it'd be wonderful for them to have that, but you said it perfectly. They are a quarterback that is in the reactive model. The PCP is the person that says, okay, I can treat some quick acute things. And then I can also hear what's going on. And I'm I have a lot of knowledge about a lot of things. And so I can hear what's going on and pretty quickly figure out where I need to send you. And then that specialist has a bunch of knowledge about that thing. And we know that intuitively with gastroenterology, rheumatology, sports medicine, cardiology, endocrinology, OB-GYNs, like we already do that in the medical space.
Right.
And to be fair, dietitians do exist in this conversation. So dietitians exist in outpatient settings. They exist in all the hospital settings. We do exist in private practice. And to be fair, Case Specific is 25 RDs in 10 locations deep because we have relationships with amazing doctors that know to do this.
Yeah.
But we're still a core concept that's localized to a region. We're not a national norm. Like you don't go everywhere in the US and like a Case Specific adjacent or equivalent exists. There's obviously some good virtual that's building up nationally, which I'm really excited for our profession. We're continuing to find ways to empower our profession. But what's most discouraging to me is that this administrative body seems to be leaning so hard into the doctor. And the fit in the 1950s, when the doctor was the smartest person in their town and you asked them about their taxes while they were hearing you cough, that is dead. They are extremely intelligent and talented people,
Yes.
but they are just as specialized as we are in what they do. And so stop trying to make them do everything because they are not
can't.
that smart. Like I'll say it this way. I consider myself to be a strong dietitian as a professional. And I have helped thousands of people with their lives. And it takes me a year
Oh, yeah.
of 1 hour visits, at least monthly. Like I'm a 12 to 25 visit kind of guy. And what you're telling me is there is somebody that is so motivating, so intelligent, so perceptive that in 5 to 15 minutes, they can fix the problem.
Yeah,
I call bullshit.
with a handout.
Yeah, with a handout and I think you should try this. I saw this gluten-free, dairy-free. I went to a conference.
Yeah.
Like that's not what they need to be doing. But more importantly, when we talk so much about what we do as dietitians, we don't tell people what to do. We help them figure out how. And so when a doctor tells someone to go gluten-free, dairy-free and come back in 6 months, that is a starting point. But without the person to meet with every week or every month in between, it will fall on its face. There is a robust absence of us in that pathway that I'm very proud to say in Pittsburgh, we've done a really good job of ameliorating, which is cool. I'm seeing it happen. It's popping up and our profession's doing its thing. But as this administrative body is building its momentum. It seems to be pulling in doctors and being delusional that they are somehow nutrition experts. It's bringing in TikTokers and influencers
Ugh.
and people that have really passionate stories. But where are the professionals that have been in the trenches for a decade plus working with this specific population?
They need to be
Hi.
part of the team of
Yes.
this movement, and the fact that they're not yet is
It's
extraordinarily
alarming.
it's very concerning.
And maybe, benefit of the doubt, I will try and not fall to fundamental attribution error. No FAE bias here. Maybe they are in the back and we just haven't heard them or seen them.
Which, fine.
Fingers crossed. But
I would love that.
once again, the reason that I put a lot more of energy into this podcast this year, and the reason why, even though I've been called a fascist a number of times online, I continue to talk about MAHA, is because our profession is needed more than ever. This is literally our time. I haven't poured hundreds of like 100-hour weeks and insane amounts of energy into our profession, and our team has collectively helped thousands, tens of thousands of people, and helps thousands every month.
Yeah.
We're not doing this to sit on the sidelines while a bunch of people with like just enough knowledge to be dangerous F it up.
Yeah.
Like, bring us in. Name the place. I'm there in a suit and tie, and I will drop some knowledge on you. And I will also recruit some people way smarter than me to come specialize in some shit, because you guys don't seem to realize that you're missing an industry that is profoundly capable of helping this problem.
I mean, it goes back to the core issue is the vast majority don't know we exist.
Yeah. Or they think that all we do is work in the hospital, which, again, I don't want this to sound like we're shading hospital RDs,
No,
because,
they're
by
very
the way,
important.
extremely important, but also like it's a segment
different.
of what we do. Yeah. There are the dietitians that work in the reactive model to help with acute care. And there are dietitians that are in the proactive model working in proactive lifestyle medicine. And both of those are essential. Just like I don't think the reactive model of care needs to go away. It just can't be the intervention for lifestyle stuff. So like we need proactive and reactive to combine and create a collaborative model of care.
The reactive needs to stay. We just need to bolster the proactive.
Yep. And so every time we talk about teaching a physician another class out of their 12 years of college so that they can somehow be brilliant enough to fix a problem that doesn't get fixed in the current model, you start to realize wrong model, wrong professional, but you're really close, because you're asking the person that's meant to be the quarterback, why are you making them the running back? Like, just, we're right here. We're here. So this,
tag me in, coach.
Yeah, put me in, coach. I'm ready to play. And so that is our shameless plug. And hopefully that one goes viral. So all you listening, hey, share this one when this clip comes out.
Could be cool.
I want to be busy. I want us to be involved in this. I want us to, dietitians as a profession,
Any
to be more
dietitian,
engaged.
please.
Yeah, there's
Any of them, all of them.
so much opportunity. And so anything else on the MAHA front for you? I think that's my soapbox, and I feel adequately vented.
Yeah. I mean, you said it wonderfully. I think it takes time for the lifestyle and behavior changes. And it takes a whole lot more than 5-minute visit. And if magically PCPs just, have all of this extra time and they can spend an hour with clients every single visit, every 2 weeks, 3 weeks, sure, great, cool. I'd love that.
Yep.
But the reality is that they don't. And there are other professions that do, that can, and that have the expertise in that area.
And we're built to do so.
Yeah, tag us in.
Yep, that's what we're here for. So here we are.